Welcome, everyone. Thank you for joining us for COVID-19 and Cancer. This is a virtual open forum for patients and families. Thank you for being with us tonight. I'm health journalist Ileana Bravo, and I will be your program moderator this evening. We do have a panel of experts joining us from Sylvester Comprehensive Cancer Center and, of course, UHealth, who will provide you with information about navigating cancer care during this pandemic time, and they will address a variety of topics, including your questions about the COVID-19 vaccine. But first and foremost, we would like to thank all of you, the patients and the families, for taking the time to be with us this evening, because after all, this is about you and for you, which is why we have offered to have so many of your questions teed up for our panelists tonight. And some of you have already submitted your questions in advance, but if you haven't, there's plenty of time to do so. Please locate the Q&A feature. It's an anonymous Q&A feature at the bottom of your Zoom screen. And that's where you're going to enter the questions throughout our discussion and presentations so that we can prepare them for our presenters to do at the end. And we're going to take as many as we can. And we do want to remind you that this session is being recorded and is going to be loaded on the Sylvester's social media channels at a later date. So stay tuned for that. But before we introduce our panelists for the evening, we're first going to hear from the director of Sylvester Comprehensive Cancer Center, Dr. Stephen Neimer. And we welcome you, Dr. Neimer, on this International Women's Day. Thank you so much for always taking the lead and being our fearless leader.
Thank you so much, Ileana. Good afternoon, everybody. I want to thank you all for attending. I want to thank all the panelists. You know, we've had a series of these discussions, and fortunately, we've made tremendous progress in the fight against the COVID pandemic, the vaccines, the testing, our understanding of treatments, and our understanding of the transmission of the disease. I'm here to introduce you a little, Sylvester, and to our efforts. You know, we've demonstrated incredible resiliency over the last year. It was roughly a year ago that we began realizing that our community was going to be affected and putting in place testing protocols. So much of what we've put in place to make our hospitals safe remains in place. It's made it very difficult, but our staff has really risen to the challenge. You know, patients come into the inpatient setting or to get chemotherapy or to get procedures, and we still have a no visitor policy, which has allowed us to keep a really safe environment. We know from national numbers that there's more than 50,000 people out there with cancer undiagnosed because they're not getting screened with mammography or colonoscopy or other things. And so one of the consequences would be later diagnosis of cancer. But now that the vaccine's rolling out, you know, there's, I think over 37 million Americans have been vaccinated so far. And we continue to get questions about how effective is a vaccine in a cancer patient. What's the timing of a vaccine in somebody with cancer? And we're beginning to get answers to some of the questions, and I'm sure we'll spend a bit of time tonight talking about that. One of the programs we have set up is which will be available soon, will be to actually test antibodies. So once you've been vaccinated, do you have detectable antibodies and how much? And the other will be our efforts to understand the rest of the immune system, which are called the T cells, and whether we can find T cells capable of protecting people from COVID infections. Our cancer center continues to see lots of patients. About a year ago, we opened up a site in Aventura. Just last month, we opened up another site in Fort Lauderdale. In the current fiscal year, we've recruited 29 faculty members, and we've put a lot of patients on clinical trials, and we're continuing to open clinical trials. You know, one of the interesting things of the clinical trials that we do require the patients to have gotten a vaccine. And so the situation continues to evolve. We continue to be at the forefront in terms of our efforts to vaccinate patients and to make sure that we keep our community safe. We've also, and Dr. Doblecki-Lewis, who's led these efforts, we've vaccinated, given out nearly 37,000 vaccines so far, and we expect to be able to vaccinate even more in the near future. So we look forward to presenting you with lots of information and answering your questions. And I'll turn things back over to Ileana. Thank you, Ileana, and thank the entire Sylvester community for all their dedication and hard work to keeping our patients safe and to finding more cures for cancer.
Thank you, Dr. Neimer. And all of you who are registered and joining us tonight are going to have an opportunity to ask questions directly to Dr. Neimer and to the rest of our panelists, whom we're going to turn it over now to for some quick introductions. So let's begin with Dr. Erin Kobetz.
Hi, everyone. My name is Erin Kobetz, and I have the privilege of being the Associate Director for Population Science and Cancer Disparity. One of the things that's been a real focus of my work at Sylvester before COVID was ensuring that all people get regular and timely access to cancer prevention. Those strategies that we know ensure earlier diagnosis of disease, which leads in most instances to better treatment outcomes. And one of the things that COVID has really imposed upon is everybody's ability to engage in prevention in a regular way. And so I think we're going to spend some time talking today about the implications of COVID on cancer prevention, the estimates for the number of individuals, particularly those from medically underserved communities who may be at increased risk of being diagnosed with late-stage disease, and really think about how we get our community back to regular screening, because we need to think beyond COVID to health more broadly.
Thank you, Dr. Kobetz. It just helps for the people who are listening to know what all of your specialty areas are so that they can prepare the questions. So now let's turn it over to Dr. Krishna Komanduri.
Hi, thanks again. Thank you, Ileana, and thank you, Dr. Neimer and group for organizing this wonderful forum. I'm the chief of the Division of Transplantation and Cellular Therapy at Sylvester Cancer Center, and that means that I'm the medical director of the program that provides blood and marrow transplants and also T-cell immunotherapies for cancer, which is really a rapidly developing way of treating cancers that fail other therapies. I actually have a background as a physician scientist studying human viral infections, and I actually started my research career at the peak of the AIDS epidemic studying HIV immunology, and for over 20 years, my research laboratory has actually helped to understand how healthy individuals control viruses and how immunocompromised patients, including cancer patients and bone marrow transplant patients, are particularly vulnerable to a variety of infections, from community viral infections to viruses that live in our bodies chronically to infections like COVID infections. So this, unfortunately, this pandemic has really provided a convergence of my longstanding scientific interests and my clinical interests, which are really to make sure that patients who seek care at Sylvester, who need blood and marrow transplants to treat a variety of diseases, especially blood cancers, have the best possible outcomes that they can, including from their cancer therapy and making sure that they don't develop life-threatening infections in the context of that cancer therapy.
Perfect. Thank you, Dr. Komanduri. Dr. Suzanne Doblecki-Lewis, do you want to go next?
Sure, thanks, Ileana. Hi, Suzanne Doblecki-Lewis. I'm one of the faculty here at UHealth in infectious diseases. And generally, I study prevention of infectious diseases, specifically relevant to today. I was our local University of Miami principal investigator for the Moderna vaccine trial, which was the second COVID vaccine that was authorized under EUA. And many people think that the study is over now that the vaccine is authorized. It actually is continuing to go on. So we're hoping to learn a lot more about how the vaccine works, how long it lasts, and what kind of protection we can expect to get from it over time, as well as transmission. So looking forward to answering questions tonight. Thanks.
And we are pretty sure you're going to get a lot of those questions about the vaccine tonight. So our last panelist will be Kathy Stella.
Hi, I'm Kathy Stella. I'm the AVP of Ambulatory Operations, and I oversee vaccine operations. So we recently consolidated to one site where we are vaccinating patients over 65 and those that are below 65 and are deemed medically vulnerable. They are all UHealth patients and Florida residents. So I oversee that area, and I look forward to answering any questions about vaccine operations.
Great. All right, so let's jump right into answering questions. These are the ones who were submitted in advance by patients. So let's tee up the first question for Dr. Doblecki-Lewis, and that is, who qualifies to get the vaccine now? Because we know that the guidelines and everything continues to change. So right now, who qualifies to get the vaccine?
Sure, you're right. This is definitely a minute-to-minute question because the guidelines are constantly evolving. And I think one thing to keep in mind is that here in Florida, we're bound by the decisions that are made at the state level. And beyond that, each vaccine site is given a directive, which can change from time to time, even from day to day, about who is to be prioritized at their site. So it's a little bit confusing to follow. You may remember that we started off with healthcare workers, nursing home residents, and then quickly after that, people who are over 65 years old. We've now moved through to people who have comorbidities, who are less than 65 years old, but that varies a bit from site to site. So at some sites, those comorbidities may be quite restricted. And again, a lot of this comes from the instructions that that site is given from the state of Florida. At other sites, we've seen now that people who are called medically vulnerable, and their physician attests to that, for whatever reason that may be, are eligible to receive the vaccine, regardless of age, as long as they qualify for the vaccine and are over 18 years of age. So that's about the most generous that you can get at any of the sites. Here at UHealth, we are still a bit more restricted based on the directives that have come specifically to our site, but there are other sites locally that have more inclusive guidelines right now.
And here's another point of clarification on that. And that would it be UHealth patients who have their portals, their health portals within the UHealth system that have access, or does it go beyond?
So the easiest way to have access and to get quick notifications when you're eligible for the vaccine is to have the UHealth portal activated. That does allow much more convenient access to the vaccine and scheduling. So strongly recommended. There is an effort to reach out to people in the UHealth community who meet criteria for vaccination but do not have UHealth portal. But that is a much more difficult process and slower. So definitely the UHealth portal is the way to go if possible.
Okay, perfect. And Kathy, can you elaborate further on that or go further on that on this point?
Yes, I agree with Dr. Doblecki-Lewis that if you set up your My Chart with the UHealth portal, it's the easiest way to go. But because a lot of patients do not have that access, we have been able to target them through text messages and email communications where we can either link them to set up a UHealth portal account or to the Vax support line.
Yeah, and it is not difficult, by the way, for all of you listening, because I myself had to do it, and it took just a matter of minutes, and it can be done, and it helps you get through the system faster. Okay, so here's one now for Dr. Komanduri. I'm going to direct to you. If I'm on immunosuppressants, will the vaccine still work?
That's a great question. So, the American Study of Hematology and the American Study for Transplantation and Cellular Therapy have actually developed joint guidelines because of the lack of clear information. The vaccine studies, even though over 70,000 individuals were treated on the various vaccine studies, did not concentrate specifically on immunocompromised patients. So teams of experts, consensus experts like Dr. Doblecki-Lewis and others who specialize in taking care of infections in immunocompromised patients have gotten together and developed guidelines. And those guidelines suggest that patients should get vaccinated in general, even though they may have less than optimal responses. And for example, another question that's come up in the chat is, if you've had a stem cell transplant, when should that occur? And the current recommendations of, again, this ASTCT guidelines suggest that individuals who are at least 3 months out from stem cell transplant should get the vaccine. Now, unlike a healthy individual who is extremely likely to have an outstanding immune response following a vaccine, patients who are on immunosuppressive therapy or who have had a stem cell transplant need to realize that they may not have an optimal response. We don't know if the degree of protection will be the same as it would in other individuals. And indeed, there's some reason to think that it may not be quite as effective, but the risk is extremely low to zero. And the benefit in terms of preventing an infection that is far more likely to be life-threatening in a stem cell transplant patient or a patient on immunosuppression is much greater. So the answer is that even though you probably won't respond as well as your neighbor who isn't getting cancer chemotherapy or immunosuppressed, you should seek the vaccine. And I'll just state one more piece of evidence there. In the International Transplant and Cell Therapy meetings, there was actually a retrospective analysis that was actually published this year in a prestigious journal where people who had, for example, stem cell transplants and then developed COVID infection were analyzed with respect to their outcomes. And while maybe 1% to 2% of individuals in the general population who get a COVID infection might die of that infection, unfortunately, individuals who had stem cell transplants and got COVID-19 infection, about 30% of them actually died within 30 days of developing COVID-19 infection, despite the fact that those infections often happen quite late, as long as 1.5 to 2 years out from the transplant. So this is a very serious infection in immunocompromised patients and in cancer patients. And even though the vaccine isn't probably perfect, it is very effective and very safe. So we do recommend, as long as you're out from 3 months out from stem cell transplants, and even if you're on immunosuppressive therapy, that you do seek vaccination.
Dr. Doblecki-Lewis, would you like to expand on any of the points that Dr. Komanduri made on this point?
No, I think those were excellent points. I think the main take home is that even though we know that the response may not be perfect, it's still definitely better to get the vaccine, and we've seen quite well that it's very safe. So definitely on the safe side is taking the vaccine. I think because the responses are variable and may not be terrific, still taking precautions after receipt of the vaccine is really important. We saw today that the CDC relaxed some precautions for people who are vaccinated, getting together with others who are vaccinated, and that's terrific. But if you are immunocompromised in any way, and certainly from stem cell transplant, those guidelines would not be quite as flexible. So I think, talking with your physician about what's appropriate and what you can expect from a response, and probably still taking precautions is important too.
All right, let's transition over to Dr. Neimer. And this is a question from a cancer survivor. Is it okay to get the vaccine? And I know that this is a large area of, because we're seeing these come over the chat. There are cancer survivors recently, years ago, etc. So Dr. Neimer, could you discuss some of this?
The answer is yes. that the trials that were published in the New England Journal of Medicine, the Pfizer and the Moderna trial, were really remarkable. That between the two trials, in which half of the patients got the vaccine and the other half got the placebo, there was over 35,000 people who got vaccinated. And in both trials, there was one of these patients who was hospitalized with significant COVID. And there were some patients, that got COVID, but the concern is always, could you get COVID that would be so severe that you would be in the hospital or would be at risk for dying? And when you look at that, so these vaccines are incredibly efficacious. And although it's not studied exactly in cancer survivors, these are remarkable vaccines. The second is that, again, there's like 36,000 people who've gotten vaccinated, so you can tell the side effects. And if you look at the side effect profile, the first thing it says is the chance that you would have a side effect that's different than what was reported is like less than 0.001%. Okay, so that's like unbelievable, right? It's like 1 in 50,000. So the chance of having some terrible side effect is very low. The efficacy is very high. It's really like a no-brainer to take the vaccine and to protect yourself from COVID.
Exactly, because I think that the risks and benefit, we're back to that situation. Someone can survive versus any adverse effects. Okay, so here's a next question for Kathy. I'm under 65, I have cancer. Can I receive the vaccine at UHealth? And I know we already alluded to the fact that all the guidelines keep changing, but let's take this one on.
Yes, currently, if you are a UHealth patient and have cancer and it's okay with your physician to obtain the vaccine, you can have it administered through UHealth, provided that we have vaccines. Vaccine supplies are limited, so we do send out randomized invitations, but certainly when we do have the supplies, you are able to get it here at UHealth.
Okay. Dr. Kobitz, as a public health expert, what are some of the common themes you are seeing in the community?
I think the big topic of conversation right now is vaccine hesitancy. And so while many people on today's chat are very eager to get the vaccine and have concerns about how they can do so given underlying health conditions, many of the other communities that UHealth and Sylvester serves are more reticent to get the vaccine. They have historical skepticism about new medical innovation and worry that the vaccine hasn't been available long enough to understand potential long-term consequences. And the challenge that we're facing with these communities is that they're the very same communities who are at increased risk of disability and death from COVID. And so Sylvester has a tremendous foothold in our community. One of our largest commitments is to working throughout South Florida to ensure that we facilitate equitable access to cancer prevention and education and clinical trials for individuals throughout the region, even those who may never ever be patients of Sylvester. And so we are working collaboratively with the state, the Pediatric Mobile Clinic, Kathy Stella, Suzanne Doblecki-Lewis, to ensure that we can really increase vaccine uptake in the community. There's also a lot of concern and question about when things are going to go back to normal. On our university campus, we are facing a ton of COVID fatigue. The students have been doing this for a year, and it's challenging when you're 18, 19, 20, 45, to be in a state where what we know is normal is really challenged by the expectations set by public health for disease prevention and reducing risk of exposure and transmission. And so that's something else that we're really wrestling with, but I continue to take tremendous stock in the resilience of our students and the willingness of our community to listen to what we have to say about the state of the science and to be open to the possibility of prevention. So those are some of the big topics.
I can imagine. So let me remind our registrants and our attendees to, for your own privacy, try not to give us too much medical information on specific cases about your medical condition, because we'd like to keep it as private as possible. And I know some of our panelists are trying to answer questions directly, not for the live Q&A, but just that quick reminder. Now let's turn this over to Dr. Komanduri on this huge topic. Once I get the vaccine, is it safe for me to see my grandkids and my family pods beyond the people I live with? And I know that the guidelines just came out today, so maybe you can give us some more detail about that, Dr. Komanduri.
Yeah, so that's a great question. Some of you know that one of the local TV stations actually did a story on my family. My parents are, my dad just turned 85 and my mother is 82. They're reasonably healthy. They're not cancer patients, but my dad had a heart attack in his 50s and has been diabetic for 50 years, though well controlled. So we kept them in complete lockdown over the last year. I did have them when they were vaccinated, when they were 3 weeks out from their second dose of vaccines, which we were very happy that they got. They came over and they did hug my children, their 4 grandchildren, who have been they're attending school remotely, so their risk was very minimal. And I will continue to allow them to really see their grandchildren that they saw really only for a distance for a year. Now that said, and I think that the CDC did today come out with guidelines that do suggest that, for example, vaccinated groups of small individuals can interact indoors without masks, and that individuals can hug their children. The one catch is that we're here obviously talking to an audience that is for many of the individuals paying attention today are going to be at higher risk to have, again, as we talked about, a bit of a less ideal response to vaccines. And it's possible that again, that this just extraordinary level of protection that we saw in the multiple vaccine studies may not necessarily be true in our cancer patients. So what I would suggest, and again, the guidance is evolving, is that you continue to exercise caution. My parents actually wore masks when they hugged their grandchildren that day, but I am going to let them interact with their grandchildren without masks, and I think that that's actually very important for their quality of life and their happiness. But if my dad were a recovering cancer patient, I would say, yes, it's fine to visit us because your children are not attending schools and they're at low risk, but I would probably say keep the mask on. And try to limit contact, continue to use, the kinds of things that we always tell our stem cell transplant patients to use, frequent hand hygiene and other things. We've often said that the kinds of precautions that our bone marrow and stem cell transplant patients have taken for decades for granted are the kinds of things that we're all doing now. So, we've been plunged into their world as opposed to the other way around. And indeed, our patients who've had bone marrow transplants have had very compromised immune systems that really take months or even years to recover, but largely they do well because of that common sense. So I think the one thing I would say is, you should exercise common sense whenever it comes to post-cancer precautions. There are levels of risk, and there are no right or wrong answers. Important dialogue with your physician about your individual risks, I think, is very important. And it's very difficult to put an individual action in a box. Going to a movie theater, if it's the premiere of a Star Wars movie, on the Friday night that it opens, is different than a year out from a transplant, sitting in the back of a theater, on a Tuesday afternoon when there are only 3 other people in the theater, right? So even something like that we would say is an absolute no-no. There are gradations of risk, and I would say, really exercise common sense and then have an important direct dialogue with your physician about what you can and shouldn't do.
And Dr. Komanduri, is it important also to point out that with both the Pfizer and the Moderna, that the first shot alone is probably not enough to give you the protection and the immunity that you seek? Because we're hearing these questions all the time. I got my first one, I have 80%, et cetera. Could you talk about that?
Yes, that's absolutely true. We have seen, in fact, in our own patient population, individuals who have gotten COVID-19 infections between, dose 1 and dose 2. And as we know, really to get full immunity, it takes, at least 2 weeks after the second immunization. The other question that is coming up in the chat, and I know people are wondering, should I get one vaccine or another? And again, if you have the luxury of having access to more than one different vaccine, again, that's an important thing to ask your oncologist or ask an infectious disease specialist like Dr. Doblecki-Lewis, what they recommend. If you don't have a choice, I think all of the vaccines are extremely effective, and all of the vaccines have really equivalent low side effects because they're not producing a whole virus. They're really generally inducing immunity to one of the viral proteins. So I would say all of the vaccines, don't wait because if you don't have access to one vaccine or another, get the vaccine that you can get your hands on. If you have more than one vaccine, then I think have a dialogue with your doctor.
Yeah. And perfect transition to Dr. Kobitz, whom I'm going to ask, what are your thoughts on the benefits of getting the vaccine now, if you have access to it, versus later?
So this might be a question that my colleague, Suzanne Doblecki-Lewis, will tag team with me. But I think if you can get access to the vaccine, get it as soon as you can. And it's not an issue of which vaccine you get. The best vaccine you can get is the vaccine that you can get into your arm as soon as possible. And I don't know if Suzanne agrees with me or not. I generally defer to her for all of my infectious disease questions. So I'd like to hear her opinion as well.
Sure, no, 100% agree. I think that it's much better both for yourself and in general for public health for people to get the vaccine that's offered to them immediately rather than waiting. We know that all of the vaccines that are approved are excellent at preventing severe disease and death, which is ultimately what, the main thing that we are trying to avoid. And the risk of waiting, say, a month to try and get a different vaccine is much higher in terms of outcomes, not being great than getting a vaccine that's offered now. Another point is that none of the vaccines contain COVID virus or can give you COVID disease. And all of them are safe for people who are immunocompromised, meaning they don't have replicating virus of any type. So there's no, in the guidelines, there's no specifications about certain populations to receive one vaccine or the other. There's been a lot of talk about different percentages, but frankly, that's a complex conversation. It's very difficult to parse and discuss how to compare those for trials that were done differently at different times. And, we can go into more details if people are interested. But I think, in short, I completely agree with Dr. Kobitz, and the best vaccine is the one that you are offered today.
Yes, thank you. And let me keep you on screen here because these questions about the second shot having side effects, and if we can do anything to minimize those side effects.
Yeah, so it's true that for the two vaccines that require 2 doses, the Pfizer and the Moderna vaccine, the second dose, it does on average have more side effects. And by that, we mean the typical post-vaccine side effects, which can be just mostly feeling pretty lousy, kind of tired, a little bit achy, sometimes low-grade fever. The way that people can manage that is whatever way is approved by their physician for managing discomforts and kind of cold symptoms and that sort of thing. No, cold symptoms meaning the general things like achiness and low-grade fever, not respiratory symptoms, which you should not have as a result of the vaccine. But if you're, according to your physician, you're able to take Tylenol or Advil, it's perfectly reasonable to take those things after receiving the vaccine if you start to feel symptoms. And usually that does work pretty well. And recognize that the symptoms do go away typically in about a day and a half, 2 days, 3 days at most. So by the day after the next day, most people are feeling perfectly back to normal.
Okay, let me keep you for one more quick point. How long is this vaccine good for? Either Pfizer, Moderna, J&J. Do we know that yet?
That's a great question. So because this is all new, right, and the pandemic's just having its birthday, we don't have any kind of long-term data about how long the protection works. We do know that for 3 months, they're very good. They're probably quite excellent 2 to 6 months. And it looks like we're going to see a duration that's a bit longer than that. Some of this gets into questions about, is the virus itself changing? Are we going to see variants coming around? Right now, the vaccines that we have work well for the virus that's circulating now. And so, you know, I don't have that concern here in South Florida right now about vaccine efficacy, but, you know, who knows, in a year we may have different concerns. So I think time will tell, but for now it looks good. And I think at least for 6 months after, we think that we've got a good vaccine effect.
Let's hope so, right? Kathy, let's get you ready with all of these questions that everyone wants to know. Where is UHealth giving the vaccine? I know we've touched on it, but I think they want details as to where, and are there plans to expand these vaccine sites to satellite locations?
Well, currently we administer the vaccine at the Converge Miami site. It's at 1951 Northwest 7th Avenue. And our hours of operation and days vary depending on the vaccine supply. Right now, there are no plans to expand to the satellites. However, those patients that do receive their care at satellites have been included in our outreach. So they have been sent invitations at the appropriate time according to the criteria. And many of them have been coming to the Miami medical campus to receive their vaccines here. So we're at Converge.
Okay, and if any more satellite locations come into play, obviously those would be announced.
Yes, correct. We are flexible at this time. There are no plans though.
Okay. Dr. Neimer, let's bring you back into the mix and see if you can weigh in on this. The question is the vaccine is effective if a person is on chemotherapy? And can you talk about the pros and cons of vaccination and timing of obtaining the vaccine in relation to the chemotherapy treatment?
You know, the effect of chemotherapy on your immune response varies dramatically depending on what type of chemotherapy. For instance, people who have lymphoma get treatments that are designed to kill an important part of your immune system, that which makes antibodies. And so it's very difficult to think that you could be successfully vaccinated when you're on treatments that are removing the antibody production factory in your body. But for most chemotherapy, it does not really affect the immune system. And for those individuals, they can get vaccinated during chemotherapy, and they may, if they're about to end their chemotherapy, it may make sense to wait a little bit to make sure that they don't either have some danger from the shot itself. You know, if you have a very low platelet count, because it's a shot into the muscle, you could bleed into the muscle. If you have a very low white blood count, you could develop an infection. We call it cellulitis at the site of the injection. But those are things, so one wouldn't want to time the vaccine to the most vulnerable period while you're getting chemotherapy. But there are people who are on chemotherapy chronically, and one wouldn't want to delay it indefinitely for those individuals. And so the main problem is if you're getting immunosuppressive chemotherapy, because then it's very hard to imagine that you could respond to the vaccine.
Okay, so obviously,
always talk to your doctor too. That's the most important thing. Everyone's situation is different.
I think you're absolutely right to say that we know that those individuals are less likely to respond. But for example, in the stem cell transplant setting, there were a lot of people who said, well, maybe we should wait 6 months or a year before recommending immunization because historically those people are less likely to respond. And in general, the consensus of experts has been try to vaccinate earlier, for example, only just 3 months after stem cell transplant, even though responses may be impaired because the benefits are so much greater and the risk is so low. So for example, for people who are going to get cytotoxic therapy or antibody directed therapies for lymphoma, ASH, the American Society of Hematology and the American Society for Transplant and Cell Therapy have recommended that if therapies can be delayed, that individuals actually undergo the 1 or 2 dose vaccines 2 weeks before starting their chemotherapy, because that can actually boost the responses before they start. Now, many people don't have the luxury of being able to delay the start of chemotherapy, but for some, for example, slow-growing lymphomas, that is an option. But again, I do think even though you would think that these people can't respond, we have clear evidence in some trials that individuals who are getting those antibody depleting therapies and B-cell depleting therapies can again respond, and that the risks are so low that they may be outweighed by getting the vaccine. So I agree with you that really there really should be a dialogue with your primary treating physician.
Yeah, thank you, Dr. Comanduri, for weighing in on that. And to expand further, can you address this question about, does immunotherapy affect susceptibility to the COVID-19 virus, as for instance, bacteria, viruses, fungi?
Yeah, so it's an interesting thing. Many of our, when people say immunotherapy, there are really 2 different types of immunotherapy. One is where we are broad categories. One is where we actually take a patient's own T cells and redirect them to recognize a cancer. The other big class of therapies, and some of the questions in the chat are about these, are actually what we call checkpoint inhibitor therapies. And those therapies were actually taking the brakes off the human immune response's ability to recognize a cancer. And we think actually in those individuals who have checkpoint inhibitor therapy, for example, for melanoma or for lung cancer, are common indications that the inflammatory part of COVID-19 infection may actually be more severe in individuals who get those checkpoint inhibitor therapies. And again, that's a reason that getting a vaccine is actually a good thing, because it's possible that the COVID infection, not only does the virus itself injure lung tissues, for example, but the immune response can actually have an inflammatory component that can actually lead people to be severely ill. So that's actually another reason, even though so that type of immune therapy can actually leave people perhaps more vulnerable to the effects of COVID. The other forms of therapy that again, like CAR T-cell therapies or these T-cell engineered therapies, probably don't leave individuals more susceptible to COVID-19 on the basis of the therapy itself, but often those T-cell therapies are given after prior chemotherapies that have weakened the immune system. And again, for different reasons there, we think that there's strong benefit to the vaccine. So in almost every situation, the take-home point is that people are worried that they may not respond, or people are worried that maybe they'll have more side effects due to the vaccine. But again, although you should have that discussion with your doctor, the main, I think, take-home point of all of the studies of cancer patients who don't get vaccinated is that when they get COVID-19 infection, they're far more likely to die than other individuals, and that in almost all cases, there will be more benefit to the vaccine than risk.
Dr. Kobetz, let's ask this question from a first responder, and I'm assuming that would be a paramedic, perhaps a police officer. But the question is, I have concerns about getting the vaccine, but should I get it as a first responder?
So if this first responder is one of our firefighters at Sylvester who participates in the Firefighter Cancer Initiative, you know that my answer is going to be yes. And that's true for all first responders. By virtue of the work that you do, you're at increased risk of exposure. And so why not take a vaccine that eliminates that risk, or largely eliminates that risk, and allows you to do your work without the threat of compromised safety and well-being? I'm actually really surprised to see how low the interest in the vaccine has been among first responders, particularly given that they are always in vulnerable situations, whether it be showing up to a car accident or to resuscitate somebody in their personal home or running into a burning building. And so the way that I like to think of this is that the vaccine is another arsenal in our first responders, our heroes toolkit that allows them to keep safe and healthy so that they can keep the rest of us safe and healthy.
Very good message. Thank you for that. Dr. Neimer, we're getting hit with a lot of questions about radiation, those who are undergoing radiation treatment and the effectiveness of the vaccine. Can you talk to us about this?
Certainly. Once again, radiation is not radiation. So every person gets a different plan for their radiation. And so for the most part, radiation is a focused treatment directed on the cancer. For the most part, radiation is not directed against the immune system. And so that, again, each person should ask their physician, but there would be no reason not to administer a vaccine to somebody who's undergoing radiation.
And Dr. Neimer, I think that cancer patients are already fearful of contracting other diseases or infections. So does the vaccine in any way affect their cancer?
Sure. So there's absolutely no evidence in any type of cancer whatsoever that getting vaccinated is detrimental to your cancer. And so there's really no reason to think that having cancer, it could get worse by virtue of being vaccinated. So our hope is that, and we talk about herd immunity, we hope that there'll be a huge uptake. Dr. Kovitz referred to this in the community, that people will get vaccinated. The variants that we see, as Dr. Doblecki-Lewis said, can be prevented at the moment still by the vaccines. And the faster the vaccine is uptake, the less likely there are to be variants occurring, because people will be protected from getting significant amounts of virus in their body. If they're not, for many, the vaccine prevents any of the virus from getting into your body. So there's really no reason not to get vaccinated.
Okay. Kathy, we are getting a lot of questions about the My UHealth chart, and if this is something that people receive notice directly from UHealth, or is this something we should be checking our inbox and going back and forth? What's the answer?
Well, if you have a My UHealth chart that's already set up, you will be receiving communication through that. If you are, if you meet criteria but you don't have your account set up, you will get an email or a text that will send you a link so that you can set up your account. Once you have that account set up, if you were invited, but by the time that you scheduled, there weren't any appointments available, you could definitely check back into your portal and you'll see an indication on when there are more vaccine appointments available, so that you can go ahead and schedule for the vaccine. So really, to be mindful of that in your email or in a text. It will say University of Miami, so that way you can go ahead and set up the portal, because that is the easiest way to have access to schedule the vaccine.
Thank you. And for Dr. Kovitz, let's go back to someone who says they're putting off their normal screenings. And is that the right time to come back to start doing their regular screenings?
So emphatically, yes. I think early during the pandemic, our health system, as well as many other health systems throughout the country, were not doing elective procedures, including screening, because we were trying to sort of wrap our heads in clinical practice around the threat of COVID. We didn't know how it was fully transmitted. If you remember early on, there was a lot of discussion about fomites and how long virus lasted on surfaces. we now know a lot more. And our health system has been extraordinarily responsive to taking the information as it becomes available and using it to inform how we structure clinical care. We have no visitors. Our waiting rooms are not crowded. Everybody is in appropriate PPE. Anybody who comes into one of our facilities is screened to ensure that they haven't been exposed to COVID, they don't have symptoms of COVID, they haven't traveled outside of the country where the risk of exposure is unknown. And so given that there are parameters in place to keep us as safe as possible, we need to start screening because we don't want to delay regular preventive care to the point where prevention no longer achieves its intended benefit. So I had my mammogram last week at our Lennar Foundation Medical Center. I felt extraordinarily safe throughout the entire process. I actually spent time speaking with other patients in the waiting room who maybe are not as accustomed to working within a clinical facility as I am, and they all expressed similar confidence, both in the physicians and in our health care system, in ensuring that they were safe as they were maintaining their own health.
Dr. Neimer, can you talk to us a little bit about the antibody test, when that would be available? Lots of questions on this one.
We are in the process of setting up what's called quantitative antibody testing. You know, early on, Dr. Kobitz did some work in the community and others did work to see whether you could detect an antibody in somebody, and that would indicate that you had been exposed and had been infected. So the initial antibody tests were sort of a plus minus. Yes, we can find an antibody. No, we cannot find an antibody. And if we couldn't find an antibody, it meant you had not been infected with COVID. Now that we're vaccinating patients, we have the ability to actually quantify the amount of antibody that people are producing. What we don't know with certainty is how much antibody is protective. So, but we do know that it's measurable. We call it neutralizing antibody, and we will soon be testing people. So for instance, if you've had a kidney transplant or a heart transplant or a bone marrow transplant, we're going to be doing research first and just seeing how much antibody the different people produce, and then over time correlating that with whether you could or could not be infected. You know, there are other populations that we're not 100% sure because they were not in the initial trials as to how much antibody people produce. And as you've heard, we want to know how long could the vaccine last? We know that some of the cells that are stimulated in your body, those cells could live more than a decade. And so some people have said that it may be good for over a decade, but we don't know that because it's only been around for less than a year. And so we want to do the research so we can have answers to the questions that so many people want answers for. And so we're testing people, and if your physician thinks it's appropriate for you to be tested, they'll be able to order the test, and we will tell you quantitatively how much antibody you have produced.
Perfect, Dr. Neimer. Dr. Doblecki-Lewis, let's talk a little bit about the differences between the vaccine. Some people are asking, for cancer patients, does one have more side effects than the other one? Is one better than the other one? I think you're going to say any vaccine that goes into your arm is a good one, but let's talk about some of the perhaps reactions you've seen from cancer patients.
Sure. So we have three vaccines that are available under emergency use right now. Two of them are the mRNA vaccines, the Pfizer and the Moderna vaccine. Both work in very similar ways. They both have, it's a mRNA inside of basically little fatty particle that goes in, and the RNA is able, without entering the nucleus of the cells, to produce spike protein that then body produces antibodies to. Both of those require 2 vaccine shots, either 3 or 4 weeks apart. And as we discussed earlier, it's fairly common, especially after the second dose, to have some low-grade symptoms that last a few days. Those are really the main side effects that have been seen. There's been a lot of discussion about anaphylaxis. The rates of anaphylaxis are not extremely high with any of these. We're talking about, maybe 4 in a million. And generally the side effects that have been seen over time are really minimal to almost nothing above what you would expect baseline in the population. So very safe over the months that have been observed now. The Janssen vaccine is the 1-dose shot. It's a little bit different because it is a viral particle that does not make copies of itself. It's a cold virus, an adenovirus, modified to carry a little bit of code for the coronavirus in it. And that's the way that gets in and produces spike protein, again, same thing, and then antibodies to that. So it's a little bit different mechanism. The result is similar. You produce antibodies to the spike protein. Again, as I mentioned before, none of these have viruses that can replicate. The virus itself, even the adenovirus from the Janssen vaccine, cannot replicate, does not make copies inside your body, and it cannot itself make you sick. So in that sense, the end result is very similar. And, I think that if people have specific concerns, it's always helpful to talk to your provider, as we've said many, many times this evening, not just about which vaccine, but about the timing of it, especially in cancer patients who are receiving therapies. The timing is really quite important. But, it's true, that I'm not going to say to wait for one vaccine or the other. Again, just to reinforce, we know that all 3 of these vaccines are extraordinarily effective against severe disease and death. And that's really critical to remember. So yeah, I think that there are differences, but in many ways, there's a lot more similarities. The side effects are quite similar. We know that younger people have them more often than older people. Cancer patients don't necessarily have more severe side effects from these vaccines. And of course, there's many different kinds of cancer, many different kinds of treatment for cancer, and it's hard to generalize. But I think overall side effects are manageable for all populations that have received these vaccines. And I hope that tonight we've been able to assuage people's concerns about that a little bit. For sure, we know the side effects, short-term and long-term, of COVID disease are much, much worse.
Thank you so much. And Dr. Neimer, since we're coming to a conclusion here with so many great questions, we're going to turn it over to you for some closing thoughts.
Thank you very much. And I'd really like to thank everyone for staying on, and for panelists for really hitting all the important points. Dr. Doblecki-Lewis really did a great job of summarizing things. And I think that these vaccines are extremely effective. They are safe. COVID is a terrible disease in elderly people, in patients with cancer, in patients with suppressed immune system. And we are working with the state and with others to make sure we can vaccinate as many people. The good news is Publix and CVS and others, the state are vaccinating people. We encourage everybody to get a vaccine any way they can. And also, as the only university-based health system in South Florida, the people on this call and many, many hundreds of others are engaged actively in research to understand all of the best strategies to timing of vaccines, the various treatments for people who do get COVID. And we've had our health system has responded in a remarkable way to the COVID. We've had one of the lowest mortality rates of anyone. We've been able to keep our patients out of the hospital. We've introduced things like telavigilance with a Tyto device. We've been looking at new ways of diagnosing COVID with breath tests, breathalyzer tests. And that's the other part of our commitment, is not only to have all the information at hand, not only to vaccinate the community, but to do the research that's required. Dr. Doblecki-Lewis was one of the principal investigators on the Moderna vaccine. The Vice President of the United States, the former Vice President of the United States, and the governor and others came by to congratulate us on the work we're doing to help the community. And we look forward to the day when we don't have to have any more meetings to discuss COVID. It can be in the rearview mirror, and we're doing more of a retrospective look back at things. Yeah.
Thank you, Dr. Neimer, and thank you to all of our dedicated panelists for even staying over the hour, and to our patients and our families, because like we said at the beginning, this is for you and about you. We ask you to trust Sylvester Comprehensive Cancer Center with your care. Go to sylvester.org to learn more about how to make virtual or in-person appointments, and our experts will see you. And please complete the survey at the end of this. We have had a wonderful discussion. We wish you a great evening, and please stay safe out there. Good night, everyone.